mission of the Outcomes Committee is to ensure that every surgeon caring for children has the information available that would allow them to make decisions and recommendations based upon the best evidence that's available. There are, however, two primary issues that get in our way. First, as we all know, the evidence is poor. We will never have anything close to systematic reviews of several double-blinded, placebo-controlled trials to tell us how best to treat any of the disease processes we care for. The second is that it takes much too long for the findings of research or quality improvement to become incorporated into our clinical practice. So some time ago, we imagined a process in which the Outcomes Committee and the Quality and Safety Committee would work together to do several things. One, we wanted to describe the evidence as it currently exists, and this is where the systematic reviews come in. The second was to create consensus-based definitions when the literature is too highly variable, and authors are describing things that are different enough that the comparisons between one publication and another cannot be made. The third thing we want to do is to facilitate the implementation of QI projects that would allow one group or hospital to benefit from the experience and expertise of another hospital in order to speed up the process of two things. One, to get the evidence into practice faster, but second, to create a platform for ongoing and iterative improvement. We know that the evidence in pediatric surgery is lacking. It is always the first criticism of the systematic reviews that we perform. The foundation of QI work, however, is the standardized process based on either evidence of expert opinion and then improve our processes iteratively. This is simply a different path to an evidence-based practice that would respond to changing environments and practices.
Thank you, Adam, for that introduction to the concept of why we are choosing to have a joint session rather than the traditional systematic review presented by the Outcomes Committee. I think this has historically been one of the most popular sessions because we are all very evidence-driven. We want to practice in an evidence-based manner, but we are often left hanging. And I think the point Adam made about standardization, even in the absence of perfect evidence, driving QI is essential. And we hope you'll take that home when you hear our presentation today. So this is the inaugural event for what we hope will be a tradition of having the Quality and Safety Committee join with the Outcomes Committee to present systematic reviews. And as Adam mentioned, I think one of the things that has been lacking in the past, I know for myself, I've gone to a systematic review presentation and I hear what we should be doing, but then I don't know how to actually make that happen in my institution. And a great concrete example of this happened, I think it's probably 5 years ago now, when Adam Golden presented the work that he had done in Seattle on enteral access. And by a 3-year process involving all stakeholders from parents to GI to nursing and surgeons and radiologists, everyone who affected G-tube care, they were able to develop a pre-op checklist that affected how they selected patients for G-tubes, how they educated their patients pre and post G-tube placement, how they decided on intraoperative plans for G-tube placement, how they managed them post-op, and they actually showed that they decreased resource utilization. And I was very inspired by hearing his presentation, and I wanted to go home and do it at my institution, but I was very overwhelmed and I didn't know where to start. And by Adam being able to share the materials that he had developed over 3 years and also serve as a mentor for me when I had stakeholders with certain objections, and I was able to call him on the phone and ask him, how did you handle it? It really accelerated our progress, and we were able to actually bring the project to fruition within 6 months, where as in Seattle, it's taken 3 years. And that kind of led to this concept of let's build a repository where people can place materials that they've used to successfully conduct QI in their own institutions and disseminate knowledge that way. And we want to use this joint session as a way to springboard this concept of the toolkit and as a way to bridge that kind of knowledge action gap. So we all know what is possible with QI. It can help us translate evidence into practice, change culture, improve outcomes, increase value. But it's hard. We're all really busy. Most of us don't have any protected time to do QI. It's just one of the many other responsibilities that is thrust upon us. We often don't have resources. There are many institutions that don't have infrastructure to help make change happen. A lot of people suffer from lack of mentors and may have difficulty getting buy-in from their local leaders and even their colleagues. And it can be overwhelming. You don't even know where to start. So the toolkit is our answer to many of these challenges. What we have done as the Quality and Safety Committee over the last 2 to 3 years, we've been compiling materials for about 20 different conditions in pediatric surgery. And on the site, you can find protocols, checklists, order sets, patient education materials, and importantly, the references to the data that were used to build these projects. So this is kind of a picture describing the concept. You know, Adam did a project on G-tubes. He put it in the toolkit, and the hope that is we can accelerate change by using the materials that he developed and adapting them to our local environments. And most importantly, actually using him as a mentor to help us succeed in our own environments. And this can be done for many different conditions. So the topics of the systematic reviews this year are going to be enteral access and intussusception. The toolkit can be found in a couple of different places. There's a link to it directly under practice and resources on the APSA website. And that takes you directly to it. Here's a link here with a QR code that you can actually take a picture of your screen, and it takes you right into the Google site. It has also been adapted for the Ped Surg Library free channel, and it's been integrated into the Ped Surgery Not a Textbook. So if you're in the appendicitis chapter of the textbook, it will actually link you to appendicitis related QI projects. So with no further ado, we're going to introduce the presentation. One will be on intussusception, and the next will be on enteral access. And we hope that we'll be able to share the evidence that was found in the systematic reviews, and then actually share tangible ways that people have brought this evidence into their practice in their own institutions, and we'll provide you access to the materials through the toolkit.
Hi, I'm Dr. Lorraine Kelly Kwan. I am a pediatric surgeon working at Children's Hospital Los Angeles. I'm one of the members of the APSA Outcomes and Evidence-Based Practice Committee. Today, a group of us are going to talk to you about a systematic review that we've been doing over the past year, looking at updates and management of intussusception for children. Now, there's 4 general questions that we wanted to address in our systematic review. The first is whether or not antibiotics should be given prior to radiologic reduction of intussusception, and whether or not a surgeon needs to be present in the room at the time of radiologic reduction. The second question that we evaluated was whether or not repeat attempts at radiologic reduction are warranted, or should children just go directly to the operating room if radiology is unable to reduce them. The third question we looked at was, after children are successfully reduced, should they be observed in the emergency room, or do they warrant inpatient admission? And then the final question that we addressed with our review is looking at updates for best practices and operative techniques, and how are outcomes different between laparoscopic and open techniques. So overall, in our systematic review, we identified 4,256 abstracts that we reviewed amongst the 4 of us. And ultimately, we winnowed that down to include 83 manuscripts in our qualitative synthesis. And these informed the recommendations that we're going to be discussing with you today. So the first question was whether or not children should receive antibiotics before they go to radiology for reduction. We identified a single center prospective study of 27 children. And in this study, none of the children received antibiotics, but they did do blood draws and blood cultures both before and after radiologic reduction. And in no child did they identify any bacteremia. We also identified 2 additional retrospective studies looking at outcomes after radiologic reduction, comparing children who did and did not receive antibiotics. And globally overall, there really was no difference between groups. They looked at incidence of post-reduction fever, maximum temperature after reduction, the number of doses of antipyretic given, the time to oral feeds, and the overall length of stay. And there's no difference between groups. So in light of this literature, our recommendation is that administration of prophylactic antibiotics prior to enema reduction does not appear to decrease post-reduction complication and is therefore unnecessary. Now, the second part of this question was whether or not a surgeon needs to be present in the fluoroscopy suite at the time of radiologic reduction. Now, the American College of Radiology regarding this question, they state that a physician member of the surgical department should be notified before an intussusception reduction is begun and should be available in case of an emergency. Now, literature for this particular question was very sparse. We were able to identify a single institution's retrospective cohort study. They looked at 433 children with intussusception. And in this particular hospital, the attending pediatric surgeon was physically in the hospital at all times, but not necessarily in the fluoroscopy suite. Overall, only 1.4% of the cohort developed hemodynamic instability requiring needle decompression and CPR, and those children were able to very quickly go to the operating room afterwards. So with this in mind, our recommendation really mirrors our radiology colleagues. Our recommendation is that a physician capable of abdominal decompression and cardiopulmonary resuscitation should be present at the time of reduction. Also, facilities performing reduction should have emergent pediatric surgical capability available within the hospital system. Now I'm going to pass it off to my colleague, Greer, for question 2.
Hi, this is Greer Arthur from St. Christopher's Hospital for Children, and our second area of interest was on reduction of intussusception, and we looked specifically at 2 questions. We looked to see if there were any clinical parameters that allow for safely reattempting radiologic reduction of intussusception after the first attempt fails. And we call this delayed repeat enemas, or DREs. The second question was, what is the optimal time between reduction attempts? For the first question, there were 25 papers that studied delayed reduction enemas for the treatment of intussusception. And of those 25 papers, there were 11 that used the same 3 criteria for safety of DREs. And those were that the intussusception had moved, progressive movement on the initial attempt, but obviously wasn't completely successful. And then the second 2 criteria was that the patient maintained stability between the enema attempts and there was no evidence of peritonitis. Of those 11 studies, 9 of them gave us all the information on this slide. As you can see, as many as 54% of patients down to only 5.8% of patients required delayed repeat enemas in these different studies. There was a lot of variability on the type of enemas that were used. Some used air, some used barium, and some used hydrostatic reductions with ultrasound. There was no standard time interval between delayed reduction attempts. It ranged from 15 minutes to 24 hours. The number of attempts was quite variable as well. Some used 2 attempts and others used as many as 5 attempts of delayed repeat enemas. The overall success rate ranged from 46.2% in these studies up to 82.6%. So overall, the 132 out of 243 of delayed repeat enemas achieved successful reduction, so 54% of patients. This improved the overall success rate of reduction by 9.6% in these studies, meaning that nearly 10% of patients avoided surgery with delayed repeat enemas. The perforation rates for delayed repeat enemas were similar to the overall perforation rate, with the DRE rate being 0.8% and the overall perforation rate being 0.5%. Also, the results at surgery were very similar. So patients undergoing delayed repeat enemas had similar rates of resection as the overall rates of the resection for all patients undergoing reduction, meaning that the delay didn't seem to alter the operation that needed to be performed. So overall, our recommendation is that delayed repeat enemas appear to increase the success rate by about 10%. About 50% or more who fail an initial reduction will be successfully reduced by a delayed repeat enema and therefore avoid surgery. And that the surgical resection rates and perforation rates for patients undergoing DRE are similar among all patients undergoing enemas. There are no definitive protocols for DRE, but it seems that safe criteria are 1, a medically stable patient, 2, no evidence of peritonitis, and 3, the previous enema achieves a partial reduction. Next step, the next question was, what is the optimal time between reduction attempts? There were 15 papers that reported time intervals between enema attempts, but no papers that compared them between each other. The ranges of times varied between 15 minutes and 24-hour. And the highest success rate was a paper that used 45 to 60-minute intervals and had an 82.3% success rate. There were 3 reported perforations in the studies reviewed, and they occurred at 4, 6, and 10-hour intervals between enemas. So our recommendation on the optimal time between reduction attempts is that there is no study that specifically examines this timing. Waiting for an interval between 30 minutes and 4 hours is likely to be safe for repeated attempts, but this is a grade D recommendation with only level 5 evidence at this time. So now I'll pass the talk on to Regan.
Hi, Regan Williams, a pediatric surgeon working at LeBonner Children's Hospital in Memphis, Tennessee, and I am a former member of the Outcomes and Evidence-Based Practice Committee, though I have moved on to other pastures now. So question 3 really has to do with post-reduction care. And it's broken into 2 parts as well. So the first part is looking at the difference in rate of complications between discharge from the ER versus admitting the patient for inpatient observation. And when we say complications, we specifically looked at returns to the emergency department, readmissions, and recurrent intussusception. The second part of the question is just how long, if we're going to admit patients or observe them in the ER, how long do they need to be observed? And we'll address that in the second part. So the first question looks at ED versus inpatient observation. Overall, there were 12 studies that addressed this. The largest of those studies was published by Elena Barris in 2014 and included over 500 patients. What they showed was about half the patients had been admitted for inpatient observation and half were observed in the ER. Though they did show a difference in inpatient recurrence, they didn't show a difference in overall recurrence. This study, however, didn't look at ED returns or readmissions. And if you look at the table that's here, it's very busy, lots going on there, but you can see that most of the studies really have few patients that they observed, and the studies were not very routine in that sometimes ED returns were recorded, sometimes readmissions were recorded, but all the studies looked at recurrence rate. So overall, of all the 12 studies, the recurrence rate was 7.5 to 15%, with an early recurrence rate ranging from 0.6 to 2.5%. And that's important because, you know, when we decide to admit patients to the hospital, we're really looking at catching those early recurrence rates rather than allowing them to be discharged. So overall, from these 12 studies, you can see there really is very little difference in overall recurrence rate from patients that are admitted to the hospital versus observed in the ER. And there was also no difference in either emergency room returns or readmission rates. So the recommendation for question 3A is that discharge from the ED is safe. Parents should be educated on the signs and symptoms of recurrence so they know when to bring the patients back. There was one study that was small-sided that showed that children greater than 2 years of age were more likely to have a recurrence rate. And so you may want to consider in children that are slightly older to either educate the parents that they have an increased risk or maybe admitting those patients. But overall, this was all retrospective data and the grade C recommendation based on level 3 and 4 evidence. The second part is if you're going to observe them in the ER, how long do they have to stay? Overall, there were only 5 studies that examined length of observation for patients that were discharged from the ED. This range was from 2 to 8 hours after reduction, though the most common utilized period was 4 hours after reduction. So based on those few studies, the recommendation is for patients to be observed for 4 hours after enema reduction in the emergency room. And again, this is a grade C recommendation. And now I'm going to switch on over to Akemi, who's going to talk about operative management.
Hi, thanks so much, Regan. My name is Akemi Kawaguchi from UT Houston. I have the privilege of being on both the Outcomes and the Quality and Safety Committee. So on this question, we wanted to look at if there was a difference in the rate of complications for laparoscopic versus open operative management of intussusception, looking at emergency room returns, readmissions, and recurrence of intussusception. And then also we wanted to know if the appendix should be removed during intussusception surgery. So we looked at 20 selected studies. They were highly variable studies, but overall had a conversion rate from laparoscopic to open of 17%. The higher numbers tended to be in the earlier studies when laparoscopic management was just started. The recurrence rate is fairly low for intussusception of 0 to 14%, but most often between the 5 to 10% range. In terms of laparoscopic versus open management of intussusception, there were actually no significant difference in the rate of recurrence of intussusception, emergency department visits, readmissions, and complication rate. And that's looking at both short-term and long-term complications. There was, however, a shorter length of stay for laparoscopic procedures that may be somewhat biased, though, by the open procedures being somewhat sicker patients at baseline too. So our recommendation for the management of open versus laparoscopic for intussusception is that while there's no difference in complication rate nor recurrence rate for laparoscopic versus open management of intussusception, that has not been able to be reduced by contrast or air contrast or enema, an initial laparoscopic approach should be considered due to a shorter length of stay while maintaining a similar complication rate. This is also a grade C recommendation with level 3 to 4 evidence. When we looked at whether or not the appendix should be removed during operative management for intussusception, whether it's laparoscopic or open, there were 11 manuscripts that addressed this, but only one specific study that looked at operative reduction with and without appendectomy. This was a FIS database of looking at 748 patients, and they found that those that had their appendectomy performed had a significantly longer length of stay and a significantly higher cost. There were similar complications and recurrence rates, though. We determined that there are inadequate data to support the prophylactic removal of the appendix during the surgical management of intussusception. While taking out the appendix does not seem to reduce the rate of recurrent intussusception, it can be considered in the setting of inflammation or ischemia. Again, this is a grade D recommendation with level 4 evidence. So this is an algorithm that we together developed for the management of a patient with suspected intussusception. It goes from the top of a patient coming in with a possible intussusception who is either clinically well or has signs of peritonitis. Certainly if they have signs of peritonitis, operative management directly is indicated. And then there's an algorithm to follow for those who are clinically well, starting with an abdominal ultrasound if that's positive, and then going through all the different steps down with our recommendations that have been developed through this systematic review for repeat enemas if there's an unsuccessful but partial reduction, and then how to potentially discharge the patient from the emergency room and different criteria for discharge to home versus hospital admission for intussusception.
Hi, I'm Colleen Fitzpatrick. I am a pediatric surgeon currently working in an adult COVID unit here at Long Island Jewish Hospital. And I am one of the co-owners of the APSA QSC Intussusception Toolkit. So the Quality and Safety Committee has developed a variety of toolkits which are available online in a repository that APSA members can access to look at different quality improvement projects that have been done across a variety of different disease processes. And this is maintained online. So I'm going to shift gears here and show online how we can get to the toolkits. The APSA toolkits are available online, and it's a variety of quality improvement projects that have been shared across a spectrum of different disease processes. And so the benefit of the toolkits is if you're looking to develop a quality improvement project, you don't have to start from scratch because you can access projects that have been done at other institutions. So if you've just finished listening to this discussion on intussusception and you're thinking you want to develop a protocol at your own institution, you don't need to start from scratch. So if you want to access the toolkit, there's a couple different ways you can do it. One is simply going to Google and typing in APSA toolkit. And this will take you to a link where you can click and come to the APSA toolkit site. Another option is to actually go to the APSA website. And if you come to the top where it says practices and resources and you come down to quality and safety toolkit, you can also get to the toolkits through that approach. And as you scroll down, you can see there are a variety of different disease processes which are included on the toolkit website. Another option for accessing the toolkit is to go to the pediatric surgery website. And if you scroll down, there's a link here for quality improvement toolkits. And if you open this, the appearance is going to be slightly different than if you access the quality improvement projects through the other two ways that I've described already, but it has a listing of all of the disease processes for which toolkits are available. And as I said, since we're talking about intussusception today, we'll click on that. And all of the different toolkits that are available currently on the websites, as I showed them before, are listed here in just a slightly different format. So all the same information is available and accessible. And again, this is something that you can access on this website without having to be a member of, or without having to have subscribed to the pediatric surgery website. So if there are other people at your institution who may not be APSA members or may not have a subscription, they can still access the QSC toolkits through this mechanism and be able to see the information that's available. But since we're talking about intussusception, I'm going to go into the intussusception toolkit. And once you're here, you can go ahead and then click to access the different toolkits that are available. So on the toolkit website, you'll see several different folders and documents that are available. I'm going to start here in the bottom corner and the welcome document. This document is there for anybody who's coming to the toolkit for the first time. It welcomes you if you are looking to look at other people's toolkits to find out what's going to be in there. And it also welcomes you if you are looking to participate and upload your own toolkit to the site and showcase the work that you're doing at your own institution. In addition to the welcome page, there is a master list of the institutions that have listed projects already. So if you're looking to find a toolkit that might be something that you could use at your own institution, you can look at the different titles and description of the project to find one that might be applicable, and then the various institutions where this had been done, as well as contact information if you want to reach out to the person who put this on the site. We also have a document that includes links to studies that have been published regarding intussusception. So this is here as a resource to go back and review the literature. And then we have a read first template. Now this is a template that is used in all of the QSC toolkits, and it's a sheet that you'll find in each of the folders where it gives a brief overview of the project that's been done at the institution, who the different stakeholders in putting the quality improvement project into play were. So for example, in the setting of intussusception, it would likely include surgeons, it might include ED physicians and radiologists. And then the institution will also list some of the challenges and solutions that they dealt with as they were putting the toolkit into place, which will help to give you an idea of whether or not you might run into similar problems and different strategies that you might be able to use. So if you were interested in uploading your own work, whether it's intussusception or one of the other topics on the QSC website, there is a new institution folder that you can open with a blank README first document. You can download this, plug in your information related to your own institution, and then we would ask you to upload any other relevant information, so your protocol, if you have any data to share, and additionally, you can also, if you have any publications, go ahead and add a reference into the document where the reference is. We would also ask that you rename the new institution folder with the name of your own institution. And so with that, I'm going to pass the microphone back to Akemi, who is going to talk about the work that they've done at UT Houston.
All right, this is just a practical example of being able to implement a process improvement plan, and this is what we did at our hospital. We started out with a PDSA cycle, plan, do, study, act, and our plan was to try to see if we could have early discharge from the emergency room for our patients with ileocolic intussusception that had been successfully reduced by air contrast enema. Our goal was to reduce the length of stay for patients, reduce the cost of the hospital, but to continue to monitor for recurrence or readmission. So our plan included gathering our team, which included various stakeholders from pediatric surgery, from the emergency department, from radiology, and from nursing. And together we developed an intussusception management protocol. And some of the things that we addressed were that the ER was concerned that we would overload them with patients, that they would be there for too long. And surgery was concerned that patients might have reoccurrences or readmissions if we discharged home from the emergency room. So this is the protocol that we had developed at the time. It's going to be modified now as the result of our systematic review. And then what did we do? So we first educated people. We educated the physicians on our surgery team as well as the nurses We educated the physicians and nurses in the emergency room as well. And we made a plan to implement. So we started on Labor Day of 2017. We posted the protocol in the emergency department and then also put it in our resident handbook, which is like the Bible for our residents as they rotate through our service. And then we looked at what happened. In the last 5 years that we looked at for pediatric ileocolic intussusception, we had 104 total patients. Of those, 21 needed surgery and 83 were successfully reduced with an air enema. We had 6 recurrences total. Of those, 4 were in the pre-protocol implementation phase. 2 of those happened while patients were still being observed in the hospital, and then 2 happened afterwards, and then 2 following implementation of our protocol as well. We had 1 readmission, but it hadn't recurred. The patient just got readmitted because they had recurrent abdominal pain. When we look for pre and post, initially the standard of care for us was to admit patients for observation after they had been reduced. So that was almost nobody got discharged from the emergency room. So initially only 8% of patients would get discharged from the emergency room. And after implementation of the protocol, 72% of our patients are now discharged from the emergency room. The emergency room length of stay did increase slightly for the post-protocol implementation, which makes sense because they were observed in the emergency room for 4 hours was our protocol as well. The observation length of stay, if they were admitted, was the same. Our total length of stay, however, went significantly down from an average of 26 hours to 13 hours. And that translated to a decreased cost for the hospital. And so what will we do now is that we're going to continue to find ways to decrease length of stay and cost. We could streamline our process in the emergency room even more, particularly when it comes to early ultrasound and early reduction. We're going to take the pre-reduction antibiotics out of our algorithm, as we've shown that in our systematic review that it's not been shown to be helpful. And then we're going to start another PDSA cycle to improve our process. Overall, we just wanted to show that the APSA QSC toolkit is accessible to everyone. It's very easy to use. It is updated regularly by the owners of the folders within the toolkit. It's absolutely free to you and your hospital. So truly, there's no need to reinvent the wheel. If somebody's already worked on it, then you can at least use what they've made as a starting point and not have to redo everything yourself.